Good evening and welcome. I'm Vanessa Hoffman, Education and Research Manager at the Bladder Cancer Advocacy Network. Tonight we present The New Normal After Bladder Removal Surgery, Part 2. I'd like to do some quick housekeeping before we get started. You have the option of listening to this webinar using your phone or the microphone and speakers on your computer. You can click the circle next to the one that you want. We will be having questions at the end of the webinar. However, at any point, you can type in your questions into the question box in the GoToWebinar panel at the bottom of your screen. Please try to keep your questions relevant to this specific webinar and the topics. We are recording this webinar and will plan to make it available within the next 2 weeks. The number for Citrix GoToWebinar tech support is on the screen if you're having technical difficulties. Also, if you'd like to access the new normal after bladder removal surgery part 1, it's available on www.beacon.org. I would now like to introduce our distinguished speakers. First, we will have Dr. Tracy Downs. He is Associate Professor of Urology and Director of Bladder Cancer and Intravesical Therapy Programs at the University of Wisconsin School of Medicine and Public Health. He's also the Director of Bladder Cancer and Intravesical Therapy Programs at University of Wisconsin-Madison. He has a joint appointment with the University of Wisconsin Carbone Cancer Center. He completed his medical degree at the University of California, San Diego, his residency at Brigham and Women's Hospital, and research fellowship and urologic oncology fellowship at University of California, San Francisco. He specializes in the surgical treatment of urologic cancers. His clinical research emphasizes developing new therapies for genitourinary cancers, and he has a special interest in prognostic biomarkers and prevention studies for bladder cancer. Deborah Hensley will be our second speaker. She is a registered nurse in the Department of Urology at UT Southwestern Medical Center. She is a certified urologic registered nurse, URN. She is also immediate past president of the Society of Urologic Nurses and Associates. She is also a member of the Data Safety Monitoring Committee for the randomized trial titled Open versus Robotic Assisted Radical Cystectomy. We are very happy to have both of them speaking. Once again, each speaker will speak for about 8 to 10 minutes, and then we will ask as many questions as we have time for out loud for the speakers. So first up, we have Dr. Tracy Downs. I will transfer control over to you now.
Great. Hi everyone. Good evening. And Vanessa, thank you so much for that kind introduction. I'm going to get my slide set going. There we go. And hopefully that is helpful. So, go ahead.
Oh, no, I said it looks perfect.
Oh, okay, great. All righty. So this is me, and I'm a urologist here in Madison, and let's see, trying to advance my slides. Sorry about that. There we go. So what I wanted to try to do tonight is to give each one listening a sense of almost a mini consultation, as if either you are currently maybe seeing a urologist for bladder cancer or you have a loved one. And so I want to walk you through kind of how the urologist is thinking what he or she may share or may not based on the time that you have in that first initial visit. So let's talk a little bit about patient selection. And when I think about the surgeon's assessment, there are a lot of thoughts going through our minds when we see a patient, and we're trying to figure out what's the correct urinary diversion. We're thinking about the age of the patient, how healthy are they overall. We'll use the term performance status, which is, are they really active? Are they a couch potato? How many medical problems do they have? Have they had a lot of surgeries before? Do they have a lot of medical problems that makes this operation even more challenging? The specific types of surgeries they've had. Prior abdominal surgery is important. Have they had radiation? How big are they? Are they obese or non-obese? And what's their preoperative kidney function? A growing area that I've become even more interested in, and it's what I call the patient safety net. So what's their social network? Are they married? Do they have a partner? Are they single? Are they widowed? Are they the caregivers for their loved ones? Do they have family that lives nearby? All very important things to help that the success we try to achieve in the hospital actually is maintained as they go home and are cared for outside of a hospitalized setting. How motivated is the patient to have the operation? What's their desire for a certain urinary diversion? What's their understanding of the types of urinary diversion? Is it really advanced or is it very basic? So as healthcare providers, we do something called the eyeball test, and it's not that complicated. And often this now is translated into a body of research called patient frailty, trying to basically find out, can a patient go through a rigorous operation and hospitalized post-operative care? And so this first panel of patients I show you here are really individuals who I kind of would say I would be questionable if they would be good candidates for neobladders, and that's just very limited based on my first just glancing at them, or the eyeball test. Here we have a woman who's in a wheelchair. Here we have some people who look much older. What's their performance status? How healthy are they? Can they understand, go through a big operation? Now the next one, here's a group of individuals that do look healthy, but of course in an office visit, I can't really tell that. I don't know that the big bearded person runs 5 miles a day, or that this couple here enjoys biking, this person does push-ups, and these two gentlemen jog together. All very important in terms of gauging the physical fitness. So let's walk through this together. Can you identify which patient is the best patient for the neobladder? Is it this gentleman in the far left? What about this gentleman over here in the far right? And there are a lot of complicating factors that come into figuring this out. So in this case, while this patient person looks very, very healthy, distinguished, I made up a physical history of here. He's 69. He's had 3 coronary artery stents. He's had robotic prostate surgery 5 years ago, followed by radiation therapy for prostate cancer that came back, and he gets up every 1 to 2 hours at night. He's not a great neobladder candidate for several reasons. One is I'd like to get him on and off the table as quick as I can because of his coronary heart disease history. Radiation makes surgery very hard, and then also because he's had his prostate removed, he may have a very short urethra, which may make continence difficult. So he could get a neobladder, but he actually may have a poorer quality of life than if he got an ileal conduit. What about this patient? My first glance at the picture is he kind of looks either upset or a little bit grumpy. 62, retired farmer. Boy, is he healthy. He walks 5 hours a day. I wish I did that. His past surgical history is very trivial. Gallbladder surgery, that's nowhere near where bladder cancer surgery is. His appendix has been removed. He's got 5 children, 10 grandchildren. Huge safety net when he goes home for people to care for him. What about this patient here? And let me go back for a second on this patient. Probably would be a great neobladder candidate if he's interested and if he understands what is the care that's necessary on his end. Here's a patient couple, and same history, but I throw in the curveball of he's the only caregiver for his wife with early dementia. A very important aspect. Can he afford to have maybe a more complicated bladder that might have complications when he's the sole caregiver? So in many ways, it's a big, large balancing act. Not as fun as Charlie Brown and Linus, but your surgeon is juggling a lot of balls, trying to make sure that everything balances, your cancer is removed, you have a successful result there, and you're able to get a urinary diversion that you'll be happy with. Let's go into a few human anatomy slides to help you understand what really is going on with the diversion. So here's a picture of a midline incision that your surgeon would make. It would be down at this area, not up that high, if he or she were doing this operation through an open procedure. This is the urinary system. On the left, this is the male. So we have our kidneys, our ureters, the yellow tubes connecting to our bladder. in the female anatomy, we have the same anatomy with the inclusion of the ovaries and the uterus. So once the bladder is removed in both sexes, we now have to connect these ureters to additional tubes or to a new urinary diversion. So what about the gastrointestinal system? We have our large intestine and we have our small intestine. And it's really in the small intestine that we use for these diversions. I won't belabor this, but this just shows you the history of urinary diversion surgery. It started way back in 1851, and in 1871 we really started to introduce the urinary system. And then the ones diversions that are most common are the ones called the ileal loop, perfected in 1950 or initiated. And then the more common or Indiana pouch or Neobladder, which actually haven't come along all that long since the 80s. Here's a diagram showing the ureteral sigmoidostomy, which shows the sigmoid colon, and then they're grabbing the ureter tube, and they're going to implant it into the bowel here and here, and now the urine will come out into the patient's sigmoid. This was a very easy operation to try initially because you did not have to harvest extra bowel, but it was abandoned due to ureteral stricture rates being very high, risk of malignancy, and now you had to urinate in the same place that you had a bowel movement. We've moved on to more elaborate urinary diversions. We have an ileal conduit where the kidneys are hooked into a simple tube brought to the skin. We have the Indiana pouch or continent cutaneous reservoir. You make an internal pouch, but you have a limb that goes to the skin, that a catheter is advanced into the bladder to drain it, and then you have the neobladder down here where it's hooked to your urethra and you pee through your urethra. So what are the goals of urinary diversion? They're very simple. Allow for storage or conduction of urine, preserve kidney function, minimal physiologic complications, and maintain a patient's quality of life. So urinary diversions are really divided into those that are continent, meaning that you don't leak urine, and those where you, non-continent, those like an ileal conduit, and those that are continent where you don't leak urine. I'm going to skip through that one. Bowel segment selection, so it really depends on the patient's condition, their prior bowel surgery, renal function, and patient preference. So going back to this picture and highlighting the differences in the small bowel, the jejunum is higher up in the intestine and has a lot of bad properties. So we avoid this at all costs. And instead we use this portion of the small intestine that's right next to the large bowel for most urinary diversion surgery. So let's walk through the different diversions to help you feel more comfortable about the surgery that you may be deciding between. The intestinal conduit allows for shorter operative times than orthotopic diversions. They're very versatile and they're generally well tolerated. Here's a cartoon picture of the ileal conduit with the kidney, the tube draining into a conduit here. And these would be a real live picture where this is what the color of the intestine looks like. This is where actually our food passes through. Now this will be the passageway of the urine, and the yellow part is the blood supply to that ileal conduit. Here above is a cartoon showing that we've harvested this piece of intestine. We've then reconnected it back up. My kind of non-sophisticated way to explain this is it's almost like you've taken a slice of pizza, you've then reattached the pizza together, and then this part here represents the crust, or so to speak, is where the urine passes through, and then we have here the blood supply. It's pretty stretchy. It needs to be to get all the way up to the top of the skin. These are just showing surgical pictures about how we suture it to the skin. And then this would be a real live picture of here's the urinary diversion. We call it a rosebud stoma. Here's a tube that we can put in temporarily to prevent edema. And then these are the white stents, all very temporary. So what about stomal stenosis? Stomal stenosis is when the ileal conduit doesn't get up to the skin. This is one of my patients maybe about 8 years ago. She was she was heavy, and so it was hard for me to get things up to her skin level. when you look closer, this is all I had, and you can see that the urine runs right on her skin, and no matter how great the urostomal nurses are, and God bless them when there's an initial result like this, because they can make this work. But this is not optimal, and this is why we try to have it up above the skin in order to allow the urine to flow out of this area into the bag and for a better result. So these are some lists of complications with the ileal conduits. I highlight peristomal hernia that can happen where you have a bulging of other bowels, loops of intestine that push alongside. As we move on to the next urinary diversion, the continent urinary diversion, now we take a segment here, we form it into a pouch, we bring that up to the skin, and then you would catheterize into it and drain the urine. The patients that we select for this have to have very good kidney function with a creatinine under 2. They have to have good manual dexterity. I had a patient who had a very impressive intentional tremor, and he was not a good candidate for that operation. And for any continent diversion, whether it be Indiana pouch or whether it be Neobladder, the patient has to be incredibly motivated to take care and get over the hump. Now, these next couple slides are not meant to put you through medical school or through nursing school with us, but they're really just to show you the principles behind a diversion. We're trying to have a low-pressure reservoir. There's actually a formula that we follow. It's called Laplace's law, and it's basically this formula for the engineers who are listening or the mathematicians. And it comes out to a sphere, which is what we're trying to create. So when your surgeon says that he or she is going to harvest so much intestine, we usually shoot between 40 to 60, 45 to 60, and what it accomplishes is a volume that is in the 500 range. We don't want something that's 900, because that will be a bladder that you cannot drain, and you may have to catheterize after. So when we think about the continent diversions, they're the non-orthotopics. Those are the ones you catheterize through. Various names, Indiana, Coke pouch, etc. And this is just showing another schematic with the catheter going down into the bladder, draining, and then removing. This is actually a post-operative because the balloon is still inflated. And really the big complication here would be diarrhea, because what we use is there's a valve called the ileocecal valve that as we go from your small to your large intestine, so you don't just get a bolus of food or fluid heading into your large colon, it has a valve that controls the intake of our GI contents into a large bowel. We take advantage of that bowel, that mechanism, that continence mechanism here, and that's what keeps the patient dry with an Indiana pouch. And because we use that, the patient can be more prone to diarrhea. So the last diversion we'll talk about is the orthotopic diversion, or AKA the Neobladder. It's definitely more complicated. Some advantages, it's internal. It may allow people to accept cystectomy better if they're worried about having a bag, although over my 11-plus years of post-fellowship practice, I've been impressed that patients do great with all different diversions as long as they choose the correct diversion. Now, contraindications to a Neobladder would be someone who's non-compliant, who says, I'm not going to get up in the middle of the night to drain my bladder, and now they just get a large retaining bladder that maybe doesn't work well. Someone who's got a creatinine that's over 2, because now we're expecting that urine to be retained in there for periods of time, and the bowel is still absorptive, so that can make their kidney function deteriorate. Someone who's got urethral cancer, we can't hook up healthy non-cancerous tissue to cancerous tissue, and then someone who maybe doesn't have a lot of bowel to utilize. Radiation at times is a contraindication. Old age is relative. It depends. Not everyone at 72 is the same fitness levels. And then if you've got cancer in your prostate or your urethra, then that would be a contraindication. Now, one of the big things with the neobladder is while you're continent in the daytime, you do have some lapses in the nighttime when you are not continent, and you have to be willing to work through that, and that's part of the selection process. And you can see this as incontinence can be as high as 10% and mostly at nighttime. So I'm going to just show you the way we do this one more common neobladder called the Studer neobladder. And here is the large intestine. So we take a segment of intestine about 45 centimeters. We then reconnect it here so the person will have their regular bowel movements. We open this intestine up. It's called detubularization. We then sew it back together. We're still sewing it back together until it looks like baseball stitches or seams on a baseball. We then cut a hole here to connect that to the urethra. And this is what a patient looks like internally after a neobladder. So I'm going to just kind of conclude. I'll give this, said that already. So urinary diversion using bowel segments is safe and effective method for bladder replacement. You really need a skilled team, not only the urologist, they're just the tip of the iceberg, that can provide multiple options, whether it be non-continent ileal conduit or a continent neobladder. And you really need a skilled urology nurse and urostomal nurse for outstanding and optimal patient care. So I want to thank you for your attention and time, and we'll transition over to Deborah's talk. Thank you.
Thanks so much, Dr. Downs. Debbie, I am transferring control over to you.
Okay. My slides up here. Can everyone hear me okay?
Yes, you're good
Yes.
to go.
Okay, great. That off of there. Okay. So now that you've had your excellent discussion that Dr. Downs just went through with your surgeon regarding the type of diversion that will give you the best results for your lifestyle and ability to perform self-care and family support, we are going to go through some of the expectations. So the first diversion I'm going to talk about is the cystectomy with ileal conduit. And after you've made that decision, your first visit really will be pre-op testing visit where you will meet your wound ostomy continence nurse. And she will conduct
Debbie,
the stoma site.
I don't see your slides quite yet. Did you pull them up already?
Oh, I thought they were. Okay. Can you see them now?
I just saw them a second ago.
Whoops. There.
Yes, there you go.
Can you
Perfect.
see them now? Okay. Yeah. Sorry about that. So you'll meet at pre-op testing visit. You'll meet the wound ostomy continence nurse, and she will conduct the stoma site selection. And she will do this while you're in various positions like sitting, lying, bending, and standing, and looking for the flattest possible surface to avoid those skin folds, creases, and belt lines, and where the stoma site can be visible to the patient. So the site selection, it can be key to prevent complications later, and the goal is really to get the best fit so that you can take care of your stoma. And let's see, I'm going to advance here. Bowel regimens will greatly vary between surgeons. But basically, the purpose is to collapse the bowel, decrease the number of bacteria in the bowel, and hopefully decrease perforation rates and anastomotic leaks post-operatively. Some surgeons will ask you to drink only clear fluids the day before surgery or 2 days before surgery. That varies, again, widely. But the take-home message is that the result of a good bowel prep will hopefully be improved post-operative healing. So every institution varies, and just follow what your surgeon wants you to do because he knows what works best for him and his techniques. And then after surgery in the hospital, the wound ostomy continence nurse will be visiting you and showing you how to take care of your urostomy. You'll have opportunities to practice emptying and changing your appliance out, and this will increase your confidence. And it's always helpful to have the family support present to help with teaching and care of the urostomy. Emotional adjustment is not unusual, and your healthcare team is certainly available for that support for you. And one of the key stresses that I want to make here is that one of the best predictors for healing and post-op recovery is immediate ambulation. You may not want to do that, but that has really been shown to be the best predictor for recovery. Other equipment you may see are a wound drain where the bladder used to be or where it was removed. And then 1 or 2 hollow urinary stents will be seen coming from the stoma, and these are temporary. And the purpose of the stents will be to drain the majority of the urine from the kidneys while healing takes place. And stents will be removed around 2 to 3 weeks post-operatively. Again, that's a surgeon's preference. And the typical hospital stay for these surgeries is 5 to 7 days. And then once you're home, you're going to have home health support. You'll go home with some ostomy supplies from the hospital, and then the home health agency will continue to use supplies while you're under their care until discharge. And they're going to reinforce how to change your appliance, assist with any wound care management you may need, pain management, supervise your diet. You know, we want to make sure that you're getting enough protein. That's very important for healing. And then also your daily activities and other safety support areas as needed, like fall precautions. Physical therapy may be ordered for strengthening exercises after surgery also. Skin care is very important. You want to keep the skin around the stoma clean with warm water or with soap and water and patting dry well before you put your new barrier on. Again, we'll be helping you select your barrier ring and pouch sizes, and these are all measured within 1/8 to 1/4 inch of the stoma. Again, these are all important factors that go into keeping the stoma and the skin healthy. You will notice shrinkage of the stoma over the next 6 to 8 weeks, and then once the shrinkage stops, you can order pre-cut wafers. And we recommend, or the wound ostomy nurses will recommend you change your system, which is the skin barrier and the pouch, every 2 to 5 days. And then remove the barrier gently by pushing the skin away from the wafer and pulling back the wafer gently rather than pulling the wafer from the skin, and that's called the push-pull method. Recovery is really a full 6 to 8 weeks. You have to allow your body time to fully recover. These are big surgeries, and you want to avoid lifting, pushing, pulling greater than 10 pounds, excessive standing, sitting, stooping. You want to make sure, again, you eat that well-balanced diet. A lot of patients will say they have no appetite, but it's very important that you eat small meals, and that may be more tolerated because, again, the protein for helping to heal tissue and maintain your muscle mass is very important, and drinking plenty of water and liquids. To avoid constipation, you want to eat your fruits and vegetables, take your stool softeners as prescribed, and again, increasing activity with daily walking. That is so important when you get home, is to do that daily walking. And you can shower or bathe with or without the appliance, except immediately post-op when you have the stents, you'll be keeping that appliance on. Again, hydration is so important. So when you have a urostomy, you can have increased susceptibility for dehydration, especially if you live in hot climates or you're exercising, out walking. It's important to stay hydrated. And if you have diarrhea, which sometimes can be a side effect, as Dr. Downs mentioned, fluid is essential. And you have to drink water, rehydrating sport drinks, or water with minerals to replenish the body's needs, and limit the caffeinated drinks. If you're a really big coffee drinker, you can have your cup of coffee and just, have that water to kind of match it up afterwards. And the goal is that you want to see straw-colored urine in your bag. The mucus we talk about is normally made in the intestine. That promotes the passing of waste products. So the intestine, even after it's been detuberalized, will continue to make the mucus. And bacteria can adhere to the mucus. So again, fluids will keep that mucus thin and easier to pass through the stoma and through the catheters. So a little bit about urinary tract infections. The signs and symptoms can be blood in the urine, chills, nausea, or cloudy or strong smelling urine, temperature of 100.5 degrees, or pain in the back or kidney area. So if you identify that, you need to notify your physician or office. But also know that when you do have a diversion made out of bowel, that the urine is going to be colonized with bacteria, and that's due to the bowel tissue and the mucus production. So sometimes you should not treat the urine unless you are having a fever or you're really feeling ill. And again, if you're not sure, you should always consult your physician's office or nurse. And with the ileal conduit, urine is collected with a catheter gently placed in the stoma, or a clean catch method directly from a cleansed stoma. You never want to give a urine specimen from the pouch or the bag. Bacteria, again, it can increase incidence of stone formation after this surgery. So prevention of UTIs and stones really is to keep well hydrated. I know I feel like I'm saying this over and over, but 8 to 10 glasses of 8-ounce water or non-caffeinated fluids each day is great. It also will help keep the odor down. And then hand washing is essential with soap and water before and after changing or emptying your appliance or changing to the night drainage system. The nice thing about this diversion is that you can connect yourself to a night drainage system with a long tube and a large bag or bottle that's on the floor and sleep well, which many people didn't have that luxury before the surgery. And then also you want to avoid urine pooling around the stoma. So you empty your pouch at regular intervals, maybe every 2 to 4 hours, or when the pouch is about 1/3 to half full. Sometimes the volume can jeopardize the seal. And then again, at bedtime, connect your pouch to that night system and keep the urine draining away from the stoma. It's a good idea to replace the night drainage system monthly. And then traveling. You should never consider not to travel once you have a urostomy. Some tips may be that you want to wait till you're a little fully recovered and you're comfortable with changing out that appliance system. Always make a checklist of supplies that you may need, and maybe start with a short trip like a long weekend. Carry plenty of extra urostomy supplies with you. Always double the amount you think you might need, and always keep your supply company's contact numbers handy. And it's always a good idea to carry the supplies on board with you versus checking in a bag. And I just put in here a couple of travel tips. You can contact the TSA website and get information about applying for an application program for a known traveler number. This becomes very handy when you do travel. TSA will contact you, or you can contact them 72 hours in advance of arrival to the airport. So you don't have to go through a big, long explanation every time. They're going to be expecting you. You have a known traveler number. It doesn't prevent you from being screened, but it may get you through that quicker boarding area where you do the pre-check. And it's a good idea to have some pre-cut barriers in case you cannot bring scissors on the plane. And you can always request an aisle seat on the plane, and again, drink plenty of water. Exercising is so beneficial for your overall health and quality of life. You need to continue that to build strength that increases circulation, prevents potential post-op complications. And again, starting off with that easy walking program, and then, increasing that gradually. And then once you're fully healed and you're confident in taking care of your urostomy, you can go back to those favorite sports like swimming, biking, bowling, or whatever activities you like to do before. And you can always check with your healthcare provider when that is a good time for you to start. And then another diversion that Dr. Downs talked about was the Neobladder surgery, which again is a new bladder that's made from the small intestine, which he showed so eloquently on this picture. And then recovery and healing is again similar to the ileal conduit. You will have those stents, and this time a Foley catheter that drains the neobladder after surgery. And the stents again will be removed at a time determined by the surgeon. Sometimes they will do a cystogram to make sure that the neobladder is healed and has a watertight seal before they'll remove that Foley catheter. And usually the stents will come out first, and then possibly a week later or so they'll remove the Foley catheter. In the hospital, the nurses will be irrigating your neobladder frequently because there will be a lot of mucus initially, and those manual irrigations just are there to prevent clogging of the stents and the Foley catheter. And the nurses are going to teach the family members and the patient how to perform irrigations at home. So the decrease in mucus production, again, manual irrigations 2 to 3 times daily or more often is needed for excessive mucus formation. Everyone's a little bit different how much they're going to form. Cranberry or blueberry tablets have been suggested to decrease mucus production. And then again, drinking plenty of fluids makes it easier to pass. And the good news is mucus production does decrease with time. And the goal of taking care of your neobladder is that you want to expand it so that it empties, builds and empties more like a normal bladder. The men may need to sit initially to expel urine. There's certain maneuvers you can use while sitting on the toilet to make sure you're completely emptying the neobladder. The Crede maneuver is to evacuate urine by pressing on the lower abdomen. You can do Valsalva voiding, which is sitting devoid and bearing down like you're going to have a bowel movement, but you relax the urinary sphincter muscles to really get a complete emptying of the neobladder. And then it's so important are Kegel exercises, which really should be taught preoperatively, and that is to help decrease the leakage and strengthen the pelvic floor so that you don't leak after having the neobladder. You can control that continence mechanism. And then the time voiding program, this is the kind of agreements that Dr. Downs was talking about between the surgeon and the patient. You have to agree, this is like your homework, and it's a time voiding program because you want to teach that new bladder to expand and hold urine, but then also to empty it before it starts leaking on you. So this is kind of a general guideline of week 1. You know, you must set your clock or your watch, and you're going to void every hour, day and night with time voiding. And then week 2, you know, you're going to increase those intervals. And this may not be your exact methods. Everyone's a little bit different. Like you may only be able to increase at 15-minute intervals. But whatever your timing is, the goal is eventually that you'll be voiding every 3 to 4 hours during the day and maybe once or twice. I have some patients that don't void at all at night now with a neobladder. And then lastly, the continence catheterizable stoma. Again, recovery, all the things that apply for the ileal conduit and neobladder are the same here. It is an Indiana pouch that is made from small and large intestines to store the urine. And then that ileocecal valve that Dr. Downs showed us, that's what keeps the urine from leaking constantly. And then again, the cystogram for checking for healing of water-type seal. And so the goal is to drain your pouch, and that was with the catheter they showed earlier in that picture. And that has to be done at regular times to drain the urine, prevent infection, and avoid overfilling of the pouch. And again, here's a simple schematic guideline, how you would start off with week 1, maybe catheterizing the stoma every 2 hours, you know, day and night, or maybe 3 hours at night. And then week 2 to 5, you're going to gradually increase the intervals, with the goal being that you maybe catheterize your stoma every 6 hours eventually as it becomes more intact and seasoned. And again, you'll check it with your surgeon for the exact time intervals, but this is a general guide you can use. So certain issues with that pouch, Dr. Downs touched on them, is, you know, can be the incontinence from the catheterizable stoma, infections because the urine can pool at the bottom of the pouch, so sometimes it's hard to totally drain all the urine out. They do use a large spout for this surgery, as he showed us, which makes a lot more mucus. And then the stones can be more frequent because of the increased mucus, and if the urine is stagnant in the pouch, they call those reservoir or pouch stones. And again, stomal stenosis, which Dr. Downs talked on briefly. So prevention, you know, again, washing your hands with soap and water, drink plenty of fluids, flush your pouch out, and that can be done in the morning when you first catheterize, and then as needed to get that mucus and all the urine out. Have your catheter supplies with you at all times. Use water-soluble lubricants, and you'll gently put that catheter in the stoma until the urine returns, and you hold it until the urine is drained out from the pouch completely. Those are all tips to try to do the best care of that pouch. And then I just put a couple of resources that might be interesting. So thank you. I know that was quick.
All right, thank you so much, Debbie and Dr. Downs. Now we're going to do the question and answer session. I see a few people have already typed in their questions. Just the way the GoToWebinar works, you won't necessarily be able to see other people's typed in questions, but if you do have a question, please go ahead and type it under the Q&A box on your panel now. So for the first question, how long do you have to wait after radical cystectomy before exercising without fear of a hernia, and are the activity restrictions different depending on which diversion you have? I guess maybe Debbie, would you like to start with this question?
Well, sure. So, you know, when you decide to go back to your exercising, again, I go back to the full 6 to 8 weeks of recovery to really allow your body to heal, you know, as complete as possible. You can do initially exercises like walking, I think is the best. And then once you're maybe a few more months, some months out and more comfortable with things, you can start doing some of those more abdominally involved exercises. But I think a hernia belt is always a good idea if you're going to be doing some exercises that involve abdominal muscles. Dr. Downs, do you have feelings about that?
Yeah, Debbie, I agree with Debbie. Is I think those first kind of 6 to 8 weeks are really critical, and I think some of the things are, and your healthcare team, your surgeon should share with you, like for example, if maybe you're a bigger guy or a bigger gal, maybe they're a little bit more worried or concerned about the fascial closure, and so they really don't want you to stress the abdominal muscles early. I think some of the handouts maybe we send out, the patients are so great that they really take it to heart, and they'll say, well, can I do anything above 20 pounds, or can I, hold my granddaughter or my grandson? And I just kind of give a general rule that if you feel like you're getting a little bit of tightness on your abdominal muscles, that you kind of back off early on. But I agree 100% is you need to be up, walking, doing light strolls to kind of regain your functionalness so that you're walking well. And things like maybe bike riding, probably not so good, definitely for a neobladder, because you're going to put a lot of pressure on where that anastomosis is. So something like that, I would think, once we've gotten through the first full 3 months. And then our goal is to get you back to doing everything you did before the operation, and hopefully more.
And I think the hernia belt is really important.
Okay, and did you guys have anything to clarify about with exercise and weightlifting related to different diversions?
I don't know, because I think not really, because what you're most worried about is, I think, the abdominal closure. If this is maybe a person who has, let's say this is their third abdominal operation and they've had other ones, and you know that maybe their closure was a little bit more concerning, then I am worried about a hernia developing. But if it's their first operation, they're pretty fit, then I personally don't kind of limit the neobladders to, I treat them the same.
Okay, well, thank you. For the next question, I'll address this one to Dr. Downs, which is, what is the average anticipated life of a continent pouch or Indiana pouch? Is it 10, 15, 20 years? What would you say to that?
Yeah, so the question is, what is the average life expectancy of an Indiana pouch? And we quote somewhere like 10 years, but really that's probably an old quote based on the patients who, because patients didn't live much longer than maybe 10 years. That was a big success. I've got several patients in my practice who are 25 years out from urinary diversion surgery. Those individuals happen to have ileal conduits, but I don't really see any kind of finite period of time that they don't continue to function well. The things that do happen that may be minor tinkering that needs to be fixed might be some stenosis at the skin, where the skin tries to overgrow, and that can be done as an outpatient operation. It's when you have to go down and the continence mechanism is jeopardized that it becomes a more substantial operation. But really, I would say there's no time limit, because patients are doing better and living longer. Debbie, what are your thoughts? Have you, in your large practice?
I agree. I think that it's very expected to last really for 20 or more years. It's, I mean, I haven't seen anyone have any kind of problems like that. Again, the stomal stenosis with the Indiana pouch is probably what I've seen the most. But I think you've hit that just right.
All right, great. For the next question, this person was saying that most people are having a radical cystectomy when they're over 50 years old, And when the person gets older, they might not be able to cast themselves, especially if they have an Indiana pouch, for example. So what could be done, and is it possible to turn an Indiana pouch into an ileal conduit? Dr. Downs, do you want to take this one on?
Yeah, I'll take this one on. So that's a really important question, and I get this asked quite frequently, and it shows the thoughtfulness of each individual patient when they're doing their very best to make their best selection before embarking on their surgical journey, so to speak. And I think what the question behind the question is really, as I age, am I still able to take care of a more complex diversion? And I found that I think in individuals who were able to master catheterizing or managing a neobladder when they're younger, as they get older, they still maintain that same skill set, even as they age. And Vanessa, there's one other part of that question. I'm kind of forgetting my train of thought for a second, but can you repeat the question?
Sure. The second part of the question was how hard is it to turn an Indiana pouch into an ileal conduit?
Yeah, thank you. So that's very hard, and what I like to share with the patients is try to make the choice as though you only have one opportunity to choose your diversion. Now, it's a lot easier to convert a neobladder to an ileal conduit because on that picture we were showing, we make it so it's an ileal conduit at the top half of the neobladder, so we can just go in and remove the neobladder and then swing what's left or the long segment for an ileal conduit. You cannot do that for an Indiana pouch because you've selected the large bowel, and what patients aren't always aware of is when we do the connections of the ureters sutured into the bowel, they often have very tenuous blood supply, which may or may not become at risk for a stricture. And so when we know that that blood supply is stable and healthy, we hate to have to redo those. And in an Indiana pouch converted to an ileal conduit, you do have to reattach those ureters to a new segment of bowel, and it's almost like you're having to do the diversion part of the surgery all over again. Plus, you're losing more intestine because now you've lost half of your right colon plus the last 15 centimeters of your small bowel, and now you're harvesting an extra piece of small bowel. So it's much easier to go from a neobladder to an ileal conduit than it is to go from an Indiana pouch to an ileal conduit.
Wow, okay. For the next question, the person writes, why does nobody talk about total loss of sexual activity or sexual dysfunction? Do you feel it's unimportant for an individual's self-esteem and mental health? Debbie, can you take this one on?
You know, that's a very good question, and I think so many times the surgeons are focused on the cancer and getting that cancer removed, but there can be sexual life after diversion. Now we have so many medications and injection therapies that are available for patients, and I think that's something that needs to be brought up to the surgeons right up front, because there can be, and Dr. Downs, correct me if I'm wrong, some nerve sparing, especially with the neobladder, hopefully, or is that a possibility?
Yes, it is. Yes.
Yes. And then also, like I say, if you're not able to spare the nerves, then there's injection therapy. We have quite a big practice of that in our department and at our institution, and it seems to be quite successful. But I think it needs to be brought up to the surgeon, right up front immediately.
Yeah, I completely agree, and I don't know, and it's not necessary to know, but if the person asking the question was alluding to maybe for women, because I do think that is an area that we don't talk very much about, and I've seen it in patients that I've operated on. I've seen it in patients that I have been operated at other institutions where after they have the neobladder, that there may be kind of a scarring or fibrosis that's in that area that can make sexual intercourse very painful and added on top of that, not even very pleasurable. That's really an area that we don't understand very well at all. And I would say definitely in terms of our ability to do a better job for our female patients, we probably know more for men based on our knowledge in prostate cancer surgery as far as nerve sparing, the different medicines you can give, the Viagras, the pumps, the vacuum pumps, the injections. But when it comes to our women patients, we don't know that as well. We really can learn a lot from our gynecological, excuse me, oncology colleagues. In fact, here at our university, a lot of times what they'll do is they will actually do vaginal reconstruction. So it's not something most urologists do. I don't do it, but they'll, when they're doing the removal of large amount of pelvic organs, they'll have a muscle flap from the abdominal musculature swung down by the plastic surgeons to maintain the capacity of the vagina and also to allow, hopefully, for maintained or improved sexual function. So great question, a lot of room for growth in that area. And like most things in medicine, the patients are really, helping us understand where our shortcomings are.
All right, well, thank you. For the next question, this person was saying that they've found that women often don't do as well with the neobladder as men, and why would there be different outcomes? And Dr. Downs, can you address this question?
Yes, that's a very good question also, and they're right. And again, this goes back to our basic understanding lacking in terms of the different nerves in the pelvis and how they function across different genders. For example, men are more likely to be incontinent. So I showed that one slide of kind of a 95% continence in the daytime, but then in the evening is where they have issues with being dry. For women, there is something that I think happens in the operation related to the nerve structures that may cause them to lose sensation to when they're filling their bladders, and this may lead to them now suddenly, instead of when we ask you to get to that 4 to 6 hour range and then say go to make sure you empty your bladder, they'll get to that period of time without any sensation. And I had one of my patients who experienced that, who was actually the first female patient I had operated on who had that happen. I've operated on a lot of female patients, but this was the first one, and this was like in 11th year, 10th year of practice, and I'm going, gee, whiz, what's going on? And what happened is that she just didn't sense her fullness in her bladder, and then we had to go to catheterization. And what's interesting about that is that person is doing fabulous on her catheterization, and she is thrilled with her selection for her bladder. So she's still very independent. She doesn't have an outside stoma bag, which is completely fine and has great quality of life, but for her choice, she didn't want to have that. And even though she is catheterizing, she still is dry, and she's still very happy and very, good quality of life.
All right,
I think
well,
that
thank you.
happens for men, and men as well can sometimes have to catheterize, but for some reason it is a little more common in women. But there is a catheterization, which is a good. And they may not have to do it every 4 to 6 hours. I just taught a woman last week, and we agreed that she would do it, in the morning when she got up, and then maybe sometime in the evening before bedtime. So you can work out a regimen, depending on what their residuals are with the surgeon and the nurse to determine, the interval time that they need to catheterize.
That makes sense. One person just commented that post-surgical nursing support cannot be overemphasized. We've gotten very little. They had to teach the nursing staff in several cases. The next question was, how often should patients have their stoma and pouch examined by a urologist post-operatively? Debbie, would you like to answer this question?
Sure. I think every time they come in for a visit, whether it be initially, we're looking at it each time, whether it's 2 weeks, 4 weeks, 6 weeks post-op, and then each time they come in for their 3 to 6 month interval exams, and eventually yearly, I think it needs to be looked at. And I take many calls from patients that are not sure what something's going on with their stoma site. And a lot of times I'll have them send me a picture. And if I'm not sure what to do, I will share it with my woundostomy continence nurse colleagues. And I still have many patients that still call the woundostomy nurse that took care of them in the hospital. But I think that's something important that it should be looked at every time they come to the office.
Okay. For the next question, this is a little more general, but it was how many people that get bladder cancer are totally cured and remain cancer-free, a percentage. Dr. Downs, can you address this?
Yeah, so when you think, a lot of our conversation tonight has really been focused on those individuals who require major surgery for cure of their bladder cancer. But if we step back and we think about, there's on average 70,000 men and women who are diagnosed with bladder cancer each year. Of that group, 75% of them have a superficial bladder cancer, and many of those patients, while maybe in remission or having a recurrence, have long life expectancy. So, for example, there are around 585 to 600,000 bladder cancer survivors in this country each year that are still living and active in all of our spheres of our daily lives. Now, for the question for those who undergo major bladder removal surgery, that's a different answer, and that depends a lot on the stage and grade of the cancers. In a very knowledgeable audience like this in BCAN, we know that oftentimes these cancers are hard to cure and hard to beat, and kind of the quoted percentages of patients, 5-10 years after an operation, I would choose the number more 10 years, maybe that upwards to 50 to 60% of those individuals may have passed on, if not from bladder cancer, from other causes, and that has to do a lot with this cancer being seen more frequently in individuals who are well into their late 60s, early 70s, etc.
Okay. Well, thank you. For the next question, person said that they have an ileal conduit. Would some of the non-prescription products help, like D-mannose, to avoid urinary tract infections, as they would keep bacteria from sticking to the bladder wall? Debbie, can you address this question?
What was the example they said, like what? What was the Medicaid over-the-counter supplement?
Yeah, they said non-prescription products, for example, D-mannose.
Oh, D-mannose. I've not ever used D-mannose before. I've had a lot of success with patients taking vitamin C or cranberry tablets.
I'm sorry,
and
the person clarified they meant interstitial cystitis, not ileal conduit.
Oh, I'm sorry. Interstitial cystitis. That I am not as familiar with. Is that the, I believe that's the bladder installation, DMSO?
Yeah, can they rephrase the question a minute? Is it the treatment of interstitial cystitis, or?
I believe so, yeah.
So maybe they could rephrase that one, just because we could talk about it a little bit, but it's a tiny bit off topic.
Okay, yeah, I'll see if maybe we can follow up offline. For the next question, we're kind of getting almost to the close of the webinar. I know, Debbie, you mentioned a lot about getting enough drinking water and staying hydrated. Is it possible to drink too much in terms of fluids?
I think, yes, you probably could drink too much, but I think also, you can gauge your drinking by the color of your urine. You really want it to be a straw or light-colored urine. And I think, if you can get in 8-ounce glasses of water a day. That is more than what you could use, unless you're out exercising in the hot heat or something like that. But I think as long as you gauge your urine, if you're not sure, you should look at your urine, and if it's dark yellow at all, then you need to increase your fluid. So I think a good gauge is that you drink 8 ounces or 10 8-ounce glasses of water, or any beverage every day, avoiding a lot of caffeinated. Again, for coffee drinkers, I say, if you need that cup of coffee in the morning, then just follow it with another 8-ounce glass of water. But I think, 8-ounce glasses is a good gauge, but again, also use your urine color as a gauge.
Okay. Well, thank you. That's all the time we have for questions tonight. As you can see on the screen, we have another webinar coming up on Tuesday, November 4th at the same time, and it will be What Do You Wish You Had Known Before Bladder Removal Surgery, a response from survivors, which will have Dr. Jonathan Wright, a urologist, as well as a few patient advocates who've had different urinary diversions. So please join us for that as well. And thank you once again to Dr. Downs and Deborah Hensley for such a wonderful and informative webinar. That's all the time we have for tonight, so good evening.